screen. Are you able to see that? Okay.
Yep.
Yeah.
Great.
Yeah.
Thank you.
Say that.
Perfect. Shall I just start? Is everyone ready to start? I think
Yep.
you're on mute.
Oh,
Yeah.
sorry, make a start. Yeah, that'd be great. Thank you.
Perfect. So hi everyone. I'm Clemmy Johnson. I'm the finance manager for cancer at St Bartholomew's, which is part of Barts Health. And Aoife asked me to do a showcase session today to present the health tool that we've developed in St Bartholomew's Hospital as a way to support our clinicians and our managers who are non-finance focused in how we can support them in understanding NHS finances a little bit better. The aims of this tool are basically to help field questions that we get specifically around why the NHS is financed as it's financed, and further on through the tool it goes into a bit more detail about specifics to do with budget holders and what you can see on your trend. Yeah, we can share the slides afterwards. That's more than happy to do that. I'm aware most people on this call will be finance colleagues, so when I go through these slides, I'm not going to explain every single part of them because a lot of them are to do with how the financing works, and you'll already know that. But it's just to show what we think the most important things are to show our clinicians and managers. The pack starts very high level, and then as you go through, it goes into a bit more detail about what you can expect if you're a budget holder, what a trend statement looks like, those sorts of things. And I'll just run through it today, explain why we've incorporated each slide, explain our thoughts behind it. But I think the key message is when you're presenting this sort of information to your clinicians, managers, consultants, nurses, whoever it is that you are the finance manager for, to really understand why they need that information, what information that they need, and how best to explain it to them. Sometimes I think as finance professionals, we explain it in a very finance focused way. And in reality, what they're looking for is just to understand the wraparound information to do with finance. So Aoife, would you like to go on to the next slide? So when we start our sessions, we always like to start with what's their current experience of NHS finance and what they're hoping to learn. And the reason that we do this is so we can understand key topics that we need to focus on. So if their current understanding of NHS finance is very specific on I can't get my invoices paid, we know to spend a little bit more time explaining the AP process and the procurement process. But if we're speaking to a clinician who may be the experience of NHS finances, why can't we get more funding in XYZ area, then we know to explain a little bit more about the strategy behind NHS finances and why finances flow through the way they do, and maybe a little bit more on business cases and how we can support them get business cases approved. So if we go to the next slide, this is just an overview of the session for today and everything that's covered in it. So it starts off, as I said, really high level with NHS funding, why NHS is funded the way it is, commissioning, a bit of finance jargon, income and expenditure, and then it goes to more of our nitty-gritty day-to-day working, so internal reporting, SIPs, business case and governance, and external funding. And then on the next slide, this is always how we like to start, how we like to present initially. And this is taken from the King's Fund. You can find it on the King's Fund website and also when we share these slides around. This is outdated now. It's from before COVID. So I think it's from 2019. So the numbers are a bit off, but saying that, the structure is still the same. This is still how the NHS is funded. So we like to explain how we go from Treasury to Department of Health and Social Care, NHS England and SpecCom, if SpecCom's relevant to your area. And then if you just press next, Aoife, it shows that CCGs are turned to ICSs or ICBs, and we go into that on the next slide. What's really important with this is if you have someone who is struggling to understand why they can't get funded for certain things, it's important to explain that because our funding is coming from the Treasury, although the NHS is apolitical, that doesn't mean that when the politicians have a certain agenda, we aren't affected by it. So the way I like to explain this is that with the current strategy of reducing waiting lists as being the number one priority for the NHS at the moment, that would mean that they would want to incentivize our first appointments and therefore decentivize follow-up appointments. And that's why we get funded for our first appointments, but our follow-ups are under block. So it's that sort of thing that we found really helpful to explain to our clinicians, that although we're trying to do the best as an NHS organisation, we still, our activity and the way we go about our day-to-day behaviour in the NHS is impacted by what government agenda is, and therefore what Department of Health and Social Care are trying to get pushed through. So you can see that snake and how it snakes all the way through to us as provider of services, or potentially you're from the ICB or the ICSs. So, and by the way, if you have any questions along the way, just put your hands up and I'm more than happy to answer them. If we move on to the next slide. So this is just a bit of explanation about integrated care systems or integrated care boards. This is really useful for staff members to know. We often get questions about what's the difference between CCGs and integrated care boards. And I think one of the key things we like to explain to our clinicians and our managers is that the way we're being commissioned is different, which means that for any patients that we treat outside of North East London as Barts Health, I'll come on to the SLAs and grants in a bit. But for commissioning, so any patients that we're treating outside of North East London, we need to make sure we have clear data on those patients, because when in the future we need to get commissioned by different ICBs, we'll need to have that information available. So we like to explain that the way we're getting commissioned now is that North East London will pay us for the work that we do for the North East London community, and then we have to agree separately outside of the North East London CCGs or North East London ICBs how we'll get paid for those patients. So it's just about trying to understand how you explain as best to your service what the change from CCGs to ICSs means. And then on the next slide. I'm not going to go through all of these because, as most of you are finance colleagues, you'll know these already. But this is just the key areas that we think that non-finance colleagues struggle to understand sometimes, particularly to do with run rate. Within my service, and I'm sure lots of others, we have known cost pressures that are within run rate. And when people look at their budgets, they think that they are spending more than they're allowed to spend. And in reality, it's because that post has been in run rate for a while. So we like to try and explain what we mean when we say run rate. We like to explain what we say when we mean cost pressures, and then also understanding the difference between accounts payables and accounts receivables. It's something that we deal with every day, but for our non-finance colleagues, sometimes they struggle to understand that a little bit. So being able to explain that to them so they know who they need to speak to. And then accruals is also, it's something we like to explain to our colleagues. Obviously, if they're not dealing with accruals specifically, they don't need to know it. But when we have, for example, some income coming in from North East London for a new service that we're doing, and we're saying we're going to spread that over a period of time rather than put it all into our budget at once, we have to sort of explain what those accruals mean. So these are the key bits of finance jargon that we think our services struggle with sometimes. And then on the next slide. This has the role of finance within Barts Trust. This is just broken down with how Barts Trust do their finance department, so it might be different for yours. So if it is, you can edit this slide. We have it broken down between financial management, financial services, income and contracting, capital and procurement, and it's just explaining what each of those things do. You might want to edit this for your services or keep it the same, but it's basically just so that we can show that as a finance manager, when you need accounts payables, there's someone else that is actually the person in charge of that, and I'll help them get to that person, but that isn't my role. I'm not the accounts payables person. So it's just trying to explain how it's all broken down and why it's broken down like that. If we go on to the next slide. So this is another sticking point that we've noticed, is that our colleagues don't always understand the difference between capital and revenue investment. And the way we work is that capital investment isn't on our budget statements, it's just revenue. So it's just day-to-day running costs of the trust. And our colleagues may need to understand what the difference is. They understand how to get capital funded and what needs to be included in a business case and what doesn't. So we've just included a slide here to explain that difference. And next slide. It's just a bit more, this is again just a bit more about capital funding. It's what is capital, it's how it's separated, and it's just explaining that it is quite constrained at the moment. Reasoning being, we can't carry it forward, it's a set amount each year, and that has to cover the whole trust, that set amount. Then on the next slide. Again, this is, sometimes we like to sort of encourage them to play a game at this point to see if they can figure out which part of this is capital, which part is revenue, and put them into the right pots to see if they understand what we've spoken about in the past. We also try to explain a little bit about depreciation, and potentially we might also try to explain a bit about PDC, public dividend capital. It depends how much you think that the clinician or the manager's engaged with what you're saying and how much you think they want to know about those sorts of topics. So you don't have to explain it. It's just whether or not you think that they would know. And the next slide. So this is now trying to explain, so we've done the capital and revenue aspect of things. We're now trying to explain income. There's different types of income, and if they look at a budget statement, they'll see that. And it's just trying to make sure that they understand what the different types are. So patient treatment income being the income that you do to treat the patient. We've also got pass-through income, and often, especially in my services, people will look at pass-through costs and see it as such a red and see it as a huge deficit, and not realizing that pass-through costs and pass-through income should be netting off, and that's something that I should be looking at day to day. So it's explaining that to them, that pass-through is those high-cost drugs and devices that just come through the trust. We get paid for what we do. And then other patient care income, it depends how relevant this is to your services, but it's explaining that private patient income comes through into a different pot to normal patient care income, and it's treated separately. And then on the next slide, we explain a little bit about the other income that they do. So other NHS income, including distinction awards, and then charitable income and education and research income. The reason it's useful to explain these and separate it out is so that if, for example, they do receive any specific education and research income, you can explain that it's sat in that different line, and we don't include it all in the one income area. And then on the next slide, this is trying to explain the difference between block and ERF, or activity-based payments. It's sort of a game that we play. So once we've explained that payment influences behaviour, hence why if the government have a certain target of reducing follow-ups, they might incentivise first appointments instead. This then is trying to explain that why certain things would be under block and why things would be under activity-based payments. So the way we would do it is we would say, do you think activity-based payment or block payment would increase activity? You get them to guess, and then if you just click next, it will put increased activity into the activity-based payment to show activity-based payments will increase activity. The more we do, the more we get paid. And then if we just continue clicking 3 more clicks, you'll see that collaboration helps block payments, security, block payments, and competition, activity-based payments. So it is just trying to explain why we get paid for services the way we do. I know in my area, so I'm in cancer, we have a lot of follow-ups. It's trying to explain why we don't get paid for every single follow-up we do, even though we know it's a service need to see those patients for months, sometimes years after their treatment. So that's what this slide shows. And then on the next slide, it's a bit more into what is elective activity. So what will we get paid for, what's under that ERF, and then the fixed element side of things. So we're explaining that generally speaking, electives, day cases, outpatient procedures and first appointments are ERF. Obviously there are exceptions, and you might want to sit down with your service and explain exactly what they're going to get paid for and exactly what's under block. We also like to note when we do this that coding and tariffs for acuity can be something that we pay particular focus to. So if you have a BIU team, or you know your BIU team that can understand the coding aspect of things, sometimes we like to get a list of the acuities that will affect the tariffs the most, and then explaining to your service that, for example, if you have a patient who's obese, make sure you're writing that in your notes so that it can be coded so that it can get that extra tariff. So it's just trying to explain how you can generate basically the most ERF for your service. And then just explaining that the fixed elements are those non-electives, the outpatient follow-up attendances, and then other local arrangements. We have quite a lot of high-cost treatments that are under block. And again, it's all to do with that issue of trying to reduce those waiting lists, trying to get patients to come through the hospitals. That's why these things are under block, sort of whether we agree about it or not. And then on the next slide, this is just showing how much of our spend is spent in what areas, and that staffing is our number one cost in the NHS. So it's really important that services understand when we're asking for more staff for your services, that is the number one cost, and it always has been. And when we're talking about SIPs in the future, we might want to look at how we can better utilize our workforce and how our staffing does grow year on year. And the next slide. This is, again, it's something that we do sort of it's something we do throughout the presentation to try and engage the colleagues if we think that they have sort of zoned out to financing a little bit. It's just basically a game to say, can you guess how much each of these things cost? So either if you just press sort of next, the cost of each is released, and then we can encourage people to guess how much it would cost, and then we show it. So cost of 1 million surgical face masks, everyone always gets wrong, but it's just a little bit of fun halfway through. And then the next slide. This is going into detail about what a budget statement might look like. I'm not going to explain this slide because I'm sure you all are aware of how a budget statement looks and how a budget statement works, but it is really worthwhile going through this. We have at Barts a online training that you do when you become a budget holder, but what we find is that a lot of our colleagues don't necessarily engage with that training as much as we'd like. So to just spend 5 or 10 minutes with those budget holders to explain a budget statement goes a long way. And also just explaining to them that the more they get used to looking at this, the more it will make sense to them, and explaining what the key points that we are looking at will be. So for example, when it's showing the whole time budgeted, whole time contracted, and whole time worked, whole time contracted will include those maternity leave posts, people are on maternity leave, so we're not as focused on whole time contracted as we are with whole time worked. And it's that sort of thing, it's that worked variance that I'm paying attention to, especially when it comes to bank and agency nursing. So it's just explaining the key things to look at through this. And then on the next slide, we've got some a slide on SIPs. So I noticed that there was a question in the chat about someone being new to the NHS finance and they're struggling to understand jargons, especially between run rate reductions and SIPs. So I can explain this slide for your benefit, Vanessa. And it's actually really important that we make sure we can explain this to our service as well, as this is sort of bread and butter. It's what we have to do every single year. So SIPs are those cost improvement programs. It's basically a way to mitigate inflating costs within the NHS, and making sure that every year we're not just spending more and more without making any efficiencies. So what we're looking for is efficiency savings. That's how some people like to call it, rather than a SIP or a cost improvement program. It's trying to ensure value for money. It's trying to ensure efficiency. It can also help fund new development within the NHS. So if the NHS is given a pot of money every single year, but every single service spends more, then that pot of money won't go to anything new. So what we're looking at is making sure we can ensure savings so that there's a bit of extra left over for those new developments of new treatments, and new ways of working. And then there's also inflation, energy costs, and pay awards, which naturally will increase our costs, and it's trying to find a way to mitigate for those things. When we speak to our services about SIPs, we want to make it really clear that we're not trying to reduce their workforce. We're not trying to make them do more with their day without getting paid for it. That's not what we're trying to do. We're not trying to make them do more with less. We're trying to work with them to improve the way that they work. And actually, with the spread of quality improvement training that's going alongside the whole of the NHS, it should be part of ways of working that we're all doing, is trying to think, how can we do this better? How can we do this more efficiently? How can I reduce time spent on doing things I don't really want to do? So we try to explain that SIPs can come from many areas. So theatre, productivity and flow, that's a big one. Reducing length of stay so that we can get more patients through, reducing outpatient follow-ups, so doing more virtual follow-ups rather than doing them in-house, or discharging patients to GP surgeries. If there's any procurement SIPs, so if we can reduce our costs of things by going back to suppliers and asking if they can do a better deal, or seeing that or doing a new tender, seeing if there are other suppliers out there. And any green SIPs. So I know we did one about reusing walking sticks, because they used to just be used once, and now we are cleaning them and reusing them. So it's just making sure that when we talk about SIPs, the wording isn't in a way of let's do more with less. It's how can we improve instead. Cost out SIPs are a big focus in my trust at the moment. I'm sure that is sort of being reflected across the NHS. So it's really trying to understand how we do that in terms of bank and agency reduction, how we do that in terms of non-pay cost reduction. Is there anything that we can reduce the cost of, e.g. sending patient letters out? Could we do texts instead? Things like that. Vanessa, did I answer your question on SIPs? Do you understand them a bit more now, or do you want a bit more information on that? Well, if you need any more information, just send me a message and we can go through them. So on the next slide, oh, great, Vanessa. The other thing I think is really, really key to be able to explain to your service managers and your clinicians is the business case cycle, especially as investment in the NHS at the moment is sort of at one of its most constrained it's ever been. And one of the only ways to get investment in your services is by fulfilling a business case. And this may be unique to your trust. You may not do it in the same way that we do it, but it's just trying to explain how that cycle works and what you need from a finance manager and what you need from procurement, might need from your IT systems. So it's trying to engage with the service about how they can do that in advance of them needing you. So the way that we would do it is we'd go through all these slides with our clinicians and we'd say, you know, is there any areas that you feel like you need extra investment in? They would say, yes, here it is. And we would sit down with them and we would say, first, we're going to do that feasibility proposal development stage. So we're going to sit down and we're going to say, what do you need and what will that achieve? Will we be getting ERF for it? Will we be seeing more patients? And those patients, that means we're freeing up service somewhere else. Will we be seeing better patient outcomes? Will we be treating patients in a better way, which means they don't then return back into the hospitals? So it's all of those conversations that you need to be having, along with what you need to do that. So workforce, non-pay costs and capital costs. And then it's working with the service to develop that business case and then go through the business case approval process. And then, as all trust should be doing, is a post-implementation review. So if a business case gets approved 6 months down the line or a year down the line, just looking and seeing if we'd achieved what we said we were going to achieve, and if not, why, and is there anything we can do to mitigate it. The business case approval process, if we go to the next slide, this is how it works within my trust. But as I said, you may want to take these slides and tweak them for your trust, but it's basically showing the governance structure. And this is actually a slimmed down version of the governance structure that we go through. But it's saying that it needs to go to our divisional meetings, and then a site meeting, and then a hospital executive board. For Barts Health, if you're not aware, we have different sites as part of our trust. So we have to get site approval and then trust approval for investments. So it's just explaining this process. And the other reason that this is really important to do with your service is that it can explain why things take time. Sometimes we have a service manager come to us and say, we need this and we need it in 2 weeks' time. And it's trying to, as if they have prior knowledge of a governance structure for business cases, it's showing them that often, if things aren't an emergency, getting things in 2 weeks is quite difficult. So it's explaining that. So it also helps your job in the future if they know that things can take a bit of time. So this is just our governance process. You may want to edit this for your trust. And then on the next slide, this again shows business cases in a bit more detail, exactly what needs to be done, who you need to speak to, and how we approach it. So covering things, you need to include an equality and equity impact assessment, and we're going to put a 15% overhead funding on top of everything for the support services, which often get left out of business cases. So it's explaining those things to our services. It's saying who needs to sign it off, and then it's showing the different steps that goes about it to get things signed off. Again, it's mitigating for the fact that governance can take a while within the NHS. It's showing that from the start. It's showing the processes that it needs to go through and showing the sign off. And then on the next slide, this is just explaining, and this just explains the standing financial instructions for the NHS. So it's the role of budget holders. And the reason that we include this towards the end is just to say that if you're a budget holder, you do have responsibilities to look after your budget in a way that fits with NHS values. So making sure we're getting that value for money for taxpayers whilst doing the best thing for the patients. And it's just explaining that is a standing financial instruction, which means it is legislation and it has to be followed. And that's why, when we look at your budgets, we will pull you up if you're overspending in certain areas. And then on the next slide, this shows about external funding. So I think there was a question about SLAs as well, and I think someone asked me if I could explain SLAs. So with external funding, we always encourage our service managers, our clinicians, our non-finance colleagues to see if that they can secure external funding. And once they have an idea if they could, we encourage them to come to us to discuss it. External funding could come from charity, it could come from another NHS trust, it could come from a private sector organisation. And all of those things need to be discussed with the finance manager to make sure that the correct arrangements are in place and also the correct governance process is followed if you need to do that. So for externally funded posts, so for people, you need to have a memorandum of understanding or a service level agreement signed. So that's an MOU or an SLA. So when people talk about SLAs, they're talking about service level agreements. And that is basically a document, a template. You can often get your template by talking to your colleagues or by various finance networks. Someone can send you a template of what an SLA should look like. And it should show you exactly what is expected from a post. And how much the post will be funded and how long it will be funded for. So for the role of the finance person in this, it is to say how much of that will be funded. So to understand the funding behind it, the actual pound amount, and to understand how long are we funded for, and then set up that agreement in terms of, are we going to do recharges? Is it going to be an invoice? And that's what the SLA should cover. What's expected from the post, that bit should be edited by the service, or your service manager or your clinician. And that's how you do externally funded posts. So it's just explaining that once they secure the external funding, we need to make sure we have that contract in place. I know we, as a site, often have people in post and no SLA, and it can be a bit tricky when we're trying to figure out if there's any costs that are missing or if we haven't been invoiced, that sort of thing. So it's just making sure that's in post to start with to make everyone's life easier. For non-pay, there needs to be a contract signed and procurement need to agree to it. And that's why it's really important that when you're getting that external funding, you go through your finance manager to start with, because it isn't always as easy as we're getting given the money so we can spend it. And procurement, are like, if you speak to your procurement colleagues, it can be really helpful in understanding exactly what you need to make sure that you're procuring in the correct way. For example, if the supplier's on the NHS framework, if they're off the NHS framework, and if there are certain amounts that we want to spend with the procurement partner, then it's making sure we go through that tender process correctly. So it's explaining that even if something's charity funded, it still has to go through that process. And then again, capital can be funded, and it's great when they find the funding, but making sure that we speak to our capital team, explain that it's going to be funded, and the service are aware that capital funding also comes with ongoing depreciation, PDC and maintenance charges, and that the trust is happy to continue with that capital even with those ongoing charges. And then on the next slide, this is just the final slide. This is out of date for us now, but it's just showing the key contacts of who you speak to in your area. And what we try and do, and we haven't successfully done yet, is include contacts from AP, AR, procurement, so that when anyone does have those particular queries, now they know what those services do, what AP does, they can speak to AP directly. And it takes some of that workload off you. So the whole of this pack is basically trying to get people a level of finance understanding that it can help their job be more effective and your job be more effective. And the next slide. It's just further information. So this is where you can find further information about finance, particularly in Barts Health. And then I think the final slide after this is just a fun graphic. After all the heavy finance information, it's just something fun to take to make the meeting a bit lighter. But does anyone have any questions for me? No? Have I bombarded everyone? Oh, there's a hand.
Hi.
Simon?
Thank you. This might be a question for. I'm a project manager within the Trust at Newcastle, so I'm not a finance person at all. And I've had an email from NHS Supply Chain, who we're collaborating with on a campus safety project, and a very financy question has come in that I don't understand the rationale behind it, and I just wondered if I could just throw that out there. This isn't a test, by the way. I'm just trying to get my head around it because I haven't found an answer within Trust. So we've been advised by sort of NHS, or supply chain rather, have been advised by NHS England that because of the election period, they're unable to issue MOUs for any non-BAU activity. And it'll be a delay in issuing those to us. And therefore, there'll be a delay in them being issued and us receiving the adjustment to our CDL and PDC. Now, they're saying that this applies to capital funding only, but not revenue funding. So I'm just trying to get my head around why our capital funding on a particular project is affected by an election when revenue isn't? And if the answer is I don't know, that's fine.
So my answer to that would be that revenue funding tends to be BAU. It's day-to-day costs, whereas capital funding by its nature is not BAU. It's those big one-off costs. So that's why they will have said it's capital funding and not revenue funding. And I think I can see your point about it being a project and therefore the revenue maybe isn't BAU because it's part of the project. But I think when the rules are being set about what happens during an election, they can't go through the specifics of this exact, like all this revenue isn't BAU. So the reason that revenue isn't covered by this is basically because it's easier to order revenue. You do it through your budget and it gets ordered like that rather than having to go through the same scrutiny as capital does. So I think it's that distinction between what's BAU and what's not BAU, and the easiest way to do that is capital isn't BAU, and revenue tends to be BAU, not always, but tends to be.
Yeah, that's helpful because they've said you can use your own capital for it, and we're like, yeah, that's fine, but we need the capital, the funding from you to be able to progress with buy hardware, obviously, the capex part of it. So yeah, that's really helpful. Thank you.
Yeah, no worries. I think there was a question in the chat from Karen. Do you have any sessions in group that offers general finance info at your trust that you just had, or do you educate based on general queries or specific to an individual? So for this pack, it's sort of come from two different places. So we have sessions within our trust called We Lead sessions. That's for any new managers where one of our finance team, so it could be myself, but we have various different sites, so it's from all the different sites, we'll go and present basic finance info, sort of like the pack I just shared with you, to their finance colleagues. Separately from that, as a finance manager, myself and my management accountant who I work with, we will make sure that our service understand the basics of finance. So the way I do that is I go and see the service managers and key clinicians and explain this to them when I have a chance, basically not during month end. I'll sit down with them for an hour and explain. So it's a bit of both. Part of it is general what we do to try and train our managers, and part of it is what I think I can do because it actually makes my job easier if the people I work with understand the basics of finance. And then a question from Katie. Do you think this approach has increased engagement with non-finance colleagues? Katie, 100%. Partly because I say to people, if I'm hosting my services, I'll say, please invite whoever you think is relevant. And then I'll meet people that I haven't met before that are key to my service, that can help my service develop. So partly from that, partly from being able to explain the way that the finance flows from government level. So as Simon's just said with his business case and the issues with MOU during election time, that can be really frustrating. But if we've already engaged with our service and explained how the finance of the NHS is affected by the government, then they're already aware of things like that. And it just sort of takes a bit of the heat off the finance colleagues because they already understand sort of the basics. So I think it's really helpful with engaging. I also think when it comes to business cases, which I spend a lot of my job doing, is writing up business cases, as long as they're aware to speak to finance colleagues before they submit a business case, the business case has got a lot more chance of getting through the proper approvals processes. We sometimes have cases where the business case will go through without ever speaking to anyone in finance, and that becomes really tricky. But because the colleagues will now know my face, they'll know my role, they'll know who I am, and they know how I can help them, and they understand that business case process, it's really, really helpful. So I'd really recommend this. Any other questions? No question. Well, if anyone has any questions, feel free to just send me an email and I'll happily answer them. I'll put my email address in the chat. And Aoife, would you be able to send round this pack for everyone?
Yeah, of course, no problem.
Perfect, thanks. And I can give you all 15 minutes back if no one has any questions. I'll stay on for a couple of minutes just in case anyone wants to catch me.
Thank you